Hey guys, welcome back to Splints and Whiskey. Sam Patrick here with a good friend of mine, Mr. Eric Crouch. We're gonna go down the rabbit hole of some medical training discussions today, and probably we'll see where else we flow. But first, do the business stuff. Splints and Whiskeys is brought to you by Life Autonomous Care Consultants. So if you guys are looking for any simulations or medical supply needs, check them out. It's LACC, Life Autonomous Care Consultants. So therefore, there we go. Did the business sponsorship. Hey, so I'll turn it over to Eric. Eric and I have crossed paths multiple times through our soft time, but you can tell your resume better than I can, so I'll let you do the talking.
No, I appreciate it. So Eric Crouch, special operations medic, spent some time down at Third Range Battalion. Moved over, was with the Civil Affairs, working over there. Very eye-opening experience throughout I guess the big ebbs and flows of GWAT. Between multiple different deployments, a bunch of different places. And then wound up transitioning out. Worked at the JSOM-TC. I was able to work on the SOCMIS refresher committee.
Right.
Very eye-opening and a great experience. Seeing all the different medics throughout special operations. Luckily, I was able to see almost two whole generations of soft medics and every single one of them.
Yeah.
Spent after was there, wound up transitioning, ran training and education for North American Rescue, and here recently, last February, broke away from that and started my own company, Precision Anatomy,
Yep.
and really focused on cadaver training and data-driven training.
That's awesome. And well, to be fair, you have Mr. Ammerman's beard, so you have to.
I'm working again. I'm nowhere near as smart as he is on anatomy, but I'm
Uh,
getting it.
yeah, no, that's awesome. Yeah, so for the listeners who aren't familiar with all our soft vernacular, so SOFMS or SOCMSC, it's our Special Operations Medic Refresher course. Every 2 years we go through that, do our 2 weeks to restart our paramedic and all that. So it's a phenomenal program. There's been some legends who've worked there, like Eric. Eric, for instance, was one of my small group instructors at one point. And of course, oh my God, I'm brain farting. Um, Win Kerr, freaking absolutely like moved on, but was the standard bearer of soft medicine for so long. So I would be remiss if I didn't give Win a shout out at some point during this whole fun talk. Um, let's talk about, man. Let's yeah. So your precision anatomy initiative or project that you're working on. What exactly is that?
So while it's more or less started at the JSOM TC, we had started getting into the point where the the level of care and the procedures we were expecting individuals to do became more and more invasive,
Hmm.
uh, especially with the bringing in fresh whole blood. PFC was very at the early days. Now I wouldn't say the earliest because that was like Vietnam,
Yeah.
um, but we really started answering into that. Um, and we actually there was one of specific event. There was an investigation on an operator that had succumbed to wounds that they believe was the result of a bad crank.
Hmm.
The initial reasoning from the medic was, well, that's how they taught us at the schoolhouse.
Mm.
So I was like, okay. And at that point in time, I was working directly underneath Win, and I was
Hmm.
doing a lot of curriculum rewrite. And I was like, all right, well, let's really dig into this. And then what I come to find out realize was the crike was done the best way for a CTN,
Right.
so
Yep.
a human model. And I was like, okay, well, we got to fix this.
Right.
At the same time, we are getting into compartment syndrome or compartment syndromes, fasciotomies, and all these other things. I was like, well, this is not the best model to use. The simulators out there. I was like, well, I'm gonna dig into cadavers.
Yep.
Um, and wound up getting an opportunity. That's why one of the reasons why I left the schoolhouse, because I was pretty much able to more or less a blank check to kind of go wherever I wanted to go.
Right.
So I started learning everything there was to do. Started building initial program, um, and then it just started really picking up. Started seeing a lot of the value. Way more
Yes.
light bulb moments
Yeah.
than I
Yeah.
was anywhere else with whatever mannequin of the
Yep.
day, whatever it is. And that's more or less what I live for. Those light bulb moments, is
Yeah.
you can connect those dots and make it make sense.
Dude, that's I'm
Uh,
gonna jump in and explain some stuff real quick. So for those who are not familiar, like we live in an ecosystem where all these words make complete sense to us. So when we say crike, that's when I take a scalpel, open a hole, open it up, put a tube down it. It's a definitive airway technique that we can do in the field that's a little bit easier than a direct laryngoscopy intubation, since I don't have to sedate you and all these other things. But here's the fun fact that I love to ask all my friendly medics is like, what are you going to do if you mess it up, since it's your crash airway? I can diatribe that all day long. And then there was another thing. Oh, I forgot what there was something else I was going to explain, but yeah. Since we have a bunch of non-medical listeners as well, so we like to try to break down the medical terminology, because that's another thing that I've learned throughout my last 4 years. I was teaching cops and firefighters and lay rescuers. Like,
yeah.
medical terminology is great if you're talking to doctors. But when I
Mm-hmm.
need the most important people in the chain of survival to understand something, like, what's hemorrhage?
Yeah.
Yeah, they literally don't know. I'm like, all right, bleeding, lots of blood, lots of red. All right.
Well, and to that point, I was literally we were just running a surgery lab down in Atlanta at Grady.
Oh yeah.
Exact same topic. I was like, when I taught T-TRIC, my focus wasn't necessarily to just teach them how to do the things. It was,
Yes.
I'm going to break this thing down and throw out and increase your depth of knowledge on terminology.
Yep.
How many different names are there for an MPA or a needle D
Right.
or just things that are it's called? So because those are the ones that are going to be my right hand people to be there
Yes.
to help me. So when I say something, when I'm stressed out and I've got that monkey on my back, they actually have an idea of what I'm actually talking about.
Right.
Um,
And that's like, I think that's the key. And you brought something up too that was poignant to me. So I when I work at the Mystic, I always tell all the medics going through, like, so the tier one, tier two, TC3 providers, which are your every service member, and then our combat lifesavers, which get a little bit more training. I tell them, like, hey, for the medics who are tier three, and then our soft medics and our higher level are tier fours, MAR, massive hemorrhage, airway problems, and like simple airway problems and simple breathing respiration problems are not the medic's problem. If I have to call medic and have a medic fix that before those other people do their job, like, people die unnecessarily. So I always like to emphasize that, and I'm going to pick your brain on this, because we hyper focus our medics on TC3,
mm,
which, yes, important, master the basics. But to be fair, when I look at a tier three and a tier four provider these days, I'm like, all right, you need to be thinking about the long term, what's next. And from your experience, like, like, so let's talk about some of the struggles of getting people to think that way.
yeah. So I think there's um, one of the biggest issues that I'm still kind of solidifying this thought process and trying to back it with some data.
Mm-hmm.
We we allow too many folks to just say, "Oh, well, that's not important for mine because military medicine is different." You look at ACLS, for example.
Mm-hmm.
Probably one of the most beneficial, pivotal things that I learned. One, there was kinematics of trauma,
Mm-hmm.
completely very basic old PHTLS class.
Mm-hmm.
Not so much the content they were doing, but it changed the way I thought. And I
Mm-hmm.
remember Sergeant Severson was
Oh,
one of
Merwin.
Merwin.
Merwin, he's a doctor now, isn't he?
Yeah. But the way he presented it, it just changed the way I thought. And
Yeah.
so like, and the same thing with ACLS, everyone's quick to discredit it. But if you really pay attention between the closed loop communication, the delegating and giving tasks, that those things, if you think passive, okay, well, yeah, I'm not going to be dealing with a whole lot of cardiac patients. It, you're focused on completely different things.
Right.
But if you're going to practice at a higher level, those are some of the things that if we discredit and we push out, then that has cascading effects. Because
Yes,
now,
100%.
in I think just 20 years of GWAT, you've got these guys that are coming in. Their only experience is, all right, patch them up. Oh, bird's inbound,
Yep.
tourniquet, a lollipop,
Yep.
and they're gone away. Not a problem. And oh, they lived. Oh, it's awesome. I did great. And so then they go back to their little SWIC tour. They go into
Hmm.
that's the only experience they have.
Yep.
So you have this endless, and it just slowly just gets worse and worse. And now we're at this point where we got to shift and we got to go back and really get these guys better clinicians and
Yes.
better clinical decision making than just doing the things.
Right.
You know,
I love hearing that because like it was interesting because I think I went to softness like 10 times and
yeah,
watching the progression of it. I remember the early softness were like no, we did it all. Like ACLS, BLS was
yep,
like was still prioritized. We did the clinical, like the medical, and then it just each time like more focused on trauma. Like the shift away from being a clinician was sliding, which understandable due to the like training requirements. So it's not on anybody, and when you only have 2 weeks, like you can shove a lot of stuff. But you hit the nail on like ACLS. Like it's a team. Like most of it's team training. Like how to
yep,
run. Like running a mega code is team management, and that's like about TC3 for my opinion. Like doing a lot of like work in the civil space. Like I personally think TC3 has no absolutely zero place in the civil space because it's like operational concept like tactical emergency casualty care. It's the same process, but the vernacular is appropriate for the civil space. Words
yeah,
have meanings like, and that like when I look at tactical combat casualty care, to me, it's a battle drill of operational leadership because care under fire, for instance, care under fire, like, okay, we have some medicine, but the medicine is getting the situation under control, which
yeah,
takes everybody around you. And that's one thing too that I try to articulate to medics is like, no, man, like this is an operational concept. A hasty tourniquet. That's another fun fact. Like hasty tourniquets. Like I talked to Ricky Ditzel last week.
yeah,
Brought this up with him. Like our hasty strap tourniquets actually do not stop any site like a site of bleeding. That if I had a true airway obstruction, like the airway problem would kill me before the bleed out from the place that a strap
yeah.
tourniquet is amenable. And it's just like these thought processes and like I took me 15, 16 years to realize that because before I started teaching cops, we had this ingrained in us like, hey, here's the solution, go.
Yeah.
So from your experience, like what have you seen that is successful to get these light bulb moments for kind of like the younger medic who hasn't thought past stuff like or hey, how do you get that to register with them?
So I think one is a couple different ways. One, the best learning tool to really kind of concrete a lot of those things is actual working and treating real sick and dying patients,
Hmm.
whether they're a geriatric or something you would never really, rarely, never say never,
Right.
rarely encounter on the military side. That's going to be the absolute best.
Hmm.
Very difficult to do, and I know the previous your episode with John Dominguez, you guys talked in depth with that whole thing and a lot
Right.
of the complexities behind that. But as leaders and evaluators and trainers, doing a way better job of crafting these scenarios,
Hmm.
all too often they'll just throw in whatever theatrical crazy wound set that's just completely unrealistic,
Yep.
or they start throwing out these vital signs that just does not compute, that does not
Hmm.
make sense, does not follow the normal pathophysiology.
Hmm.
Um, but on that side, like I've got a number of scenarios that I literally went through 72 hours of but good, better, best treatments
Yep.
and vital signs to include labs, and it takes a lot of time.
It's oh yeah,
So,
yeah.
but I think the one of the biggest things where I really try to focus in on is define training objectives
Hmm.
prior to. Don't just throw a scenario just to run a scenario
Hmm.
or dump in a 5 gallon bucket of blood. It's just nothing. I, there's one. I'll leave his name out, but probably one of the best medics that I've ever come across. Amazing individual. Um, always, it was always my mission to try to get him to the point where is that not the full failure, but get him like, oh boy, all right, that's a, and I was able to do that with nothing more than a Tegaderm, a little 2x2, squirt some little blood in it, and some grease paint.
Hmm.
But it's because the amount of time you go into actually really knowing what you're trying to drive them to, and instead of just having one set scenario with one set end state, if this guy is crushing it and he's doing everything, oh, I've got Koa 2, and this thing I'm going to start adding more complexity until
Yep.
you get to the point where you just hit that. I don't like doing the train to failure necessarily because not everybody, when you get in the psychological aspect, not
Yeah. Yeah.
everyone's going to, some people will just shut down.
Yes, sir.
But to that point to where you can see that they're hurting.
Yeah. Yeah.
They're in a spot and they realize it. And if you can get to that and then kind of lighten up a little bit and be able to let them dig themselves out, that's what it would really take. So I think just really more of a focus on quality training,
Yeah.
um, with actual end states in mind. What are
Yeah.
we ultimately trying to fix? Are we trying to improve your airway
Yeah.
management? Okay, cool. We can still add in all these other things, but us have a guiding principle of what we're really trying to drive with this.
And that's like, dude. So you're hitting nails that I love to drive home with. Like, we instructor development. Like, bro, I don't see it. I don't know what JSOM's doing these days. Like, I know Win did a phenomenal job making sure all the softness instructors are on the same sheet. But yeah, like instructor development is one of the hardest things to do, and we rely on the individual to be good. You look
Yeah,
at all of like all the like. So I had to go through the train the trainer stuff or deployed medicine for all TC3 stuff. It's all focusing on primarily how to teach, which good, bad, or indifferent, it's probably not shouldn't be done on a virtual setup. But hey,
yeah.
um, you spent a lot of time in the instructor space. You spent a lot of time as a green suitor. You spent time on the contract side. You're now doing your own thing. Um, how this is going to be broad. We're just going to
Yeah.
see where it goes. Like how do we develop instructors, knowledgeable instructors that think like you and I, who think, okay, I'm not just following an algorithm, not just following a guideline. I can flex based off what the patient's giving me. Like that is incredibly hard to develop, and without experience in bad nights, shitty situations, like you don't like how do we teach this to people that we don't have experience anymore in the military? How are we teaching people with no experience how to be an experienced instructor?
Um, well, that is tough, and I would like to. It's almost, I wouldn't say impossible. It is very tough to be able to develop an instructor without getting the actual real world experience.
Hmm.
So really is what we need to do is like things like this. We need to be able to tap into the people just because the conflict or whatever the environment's changing, that doesn't matter.
Right.
But capturing the experience that we have and then actually affording the time to properly train. Like I think each organization should have someone that is their sole job as the
Yes.
trainer.
Yes.
They go to those conferences,
Yep.
they stay up on all the publications. It has to be purposeful, to be able to fix it because
Right.
I think it was like jumping. It was like the first 4 weeks of SOCMAS, jumping into SOCMAS
Yeah.
as an instructor. Like, and I love Win to Death, and he actually did a lot, for my development because one, I was eager, excited.
Hmm.
I was always I still keep up reading between. I try to get it 10 papers a week if I can on
Overachiever.
whatever it is. Doesn't matter.
Yeah.
But like I remember my first one of my first small groups. I was pretty much expected to go. I was running a small group and I had F.
Yeah,
But
F Bowling, a legend inside the community.
oh yeah,
We'll throw his name out there.
and I mean, we're sitting there, and I remember going over Fresh Whole Blood, and we were just kind of, I think Rolo, Handicap and Range Regiment, they just kind of published that and everything. And I'm sitting there essentially telling these guys, pointing out all the wrong things in the team eps.
Hmm.
I've got the dude who probably put more effort than just about anybody else in having that in there. So that encouraged me and focused me on doing all the extra homework, spending all the extra hours to really make sure everything was iron tight and I could stand by everything. Um,
Was that class in the trailers?
yeah, it was a trailer
Yeah,
park.
I was in that one because I went through with F one time, and yeah, I think it was when you were pretty new at the schoolhouse. So
Yeah,
yeah,
it,
memories.
he, and that was Wynn's thing, man. He shoved every single SEMA, whoever it
Yeah,
was, author of all the things. They'd always go into my small group, and it's like, all
thanks,
right,
Win.
awesome.
Hey, but you know that's a testament to you, man. That's I honestly like I'm not gonna like overinflate your head, but like I still think the most valuable soft miss pull I had was when you were my SGL, going through it because it's just like and it was super formative at the time because I watched how you were doing things, and then I took that back, and it shaped how I ran training going forward as well. So like, hey, kudos to you. Like now I'm correlating a lot of this back to the man, the myth, the
Well,
legend that's sitting on the other side right now.
and quite honestly, it's not me. A lot of the stuff is just I was lucky at, like, I hit a really awesome time in different work places I've been, deployments and
Hmm.
everything. Like I still, in the back of my head, like dog bites. I was
Yep.
with came back off of a mission, and I had Doc Cotwell.
Yeah.
He was out with us, and I'll just never remember. He's like, "What antibiotic would you give him?" I was like, running around, and he goes, "Doggy, doggy." I will forever, in the back of my head, hear Russ Caldwell mention just Augie Doggy. And it's just those little
Augie
things.
doggy. Yeah.
I mean, I just trying to absorb and try to collect everything because I'm just try to do the best I can. Sadly wasn't able to stay in and do some of the things I wanted to on the military side. So I was like, all right, well, I still got a lot to give back to this community.
Yeah.
So I'm going to do every single thing I can to be as good as I can. And if I don't have the answer, I will dang sure find it for you and
Yeah.
provide you that resource.
And that's awesome that like knowing that you went to over to NAR to work that side with Ethan Miles, and now you're doing your own thing. Like that to be fair, like it's how we can give back the most is getting like because a lot of the stuff I was just with Nick Graham doing some work in the Netherlands, and it's just like building this network, like the medical mafia that is like the Mike Hetzlers of the world that have brought us all together to like make continue this forward. It's like all right, and this is like doing this podcast like is part of my like I'm trying to get the next generation to like all right, here we go, guys. Like this is some of the stuff we've done, continue paying it forward, because like training is hard, and unless you've had patients die on you or get thrown the pregnant polytrauma on a casevac, and you're like, I never thought I had to think about Category X drugs in the back of a helicopter in Afghanistan ever.
Yep.
Like, and then to be fair, like I gave Alex Hall a shout out last time. He's one of our trainers at the regiment right now. They have a scenario where they do a casevac of a pregnant female who then delivers in the back of the helicopter and has postpartum hemorrhage.
Yeah.
Like it like weird things happen, and like it's not like, hey, okay, this is not traditional, but like it makes you think so much more.
Well, no, it was like I always like to throw out again, bring up F again. One of his vignettes. I was at SOCOM, and I was just doing a little pre-brief because I was speaking on a Moscow event in was that was for Afghanistan. So I
Hmm.
was briefing all them, Doc Paramore and all them. And
Yeah.
I'm sitting there walking through, and sitting at FSS, and I see an AEM or I think it's like AEM or something. I'm like, what is? Why would you have that on you? He's like, read it. Giving birth to a baby on the objective.
Hmm. Hmm.
It no, there's no telling what's going to walk in that door, and you have to
Well,
deal with it. It's up to us to be able to stay on top of our stuff.
well, and that's the thing is like you spend time in civil affairs. So for people who are not familiar with the Army soft programs, like civil affairs is the, for lack of a better term, hearts and minds arm that has objectives we can't talk about on open forum, but like the stuff that you guys would come across during your medical civil affairs missions, like
Yeah.
it's one of those where I'm like, all right, we still have a massive element in soft that, hey, well, that has huge opportunity to go get experience if that
Yep.
that med cap is pushed by the command.
Mhm.
And to be fair, like I was always jealous of talking to you, like jealous, not the right term, but like
Yeah.
low key
Envious.
envious of the stuff you guys got to do because you got to do some like legit dirt medicine for people that you weren't going to keep.
Yep.
Um,
Yeah,
yeah.
and that was a very exciting. I mean, when I first got over to civil affairs, it's evolved so much, and between the massive growth and everything. But when I got there, it was incredible. One, my first sergeant was Ian Dunbar, so we actually became
Legend.
the yeah. Um, Come to find out, on the flight line deploying with him as my first sergeant, he was actually his team was with us when I deployed with Ranger Regiment. Yeah, small world. But
Yep.
anyways, like being able to do way more than just kind of sick call and trauma.
Mm-hmm.
I mean, I had a pediatric patient with meningitis I
Mm.
had to manage, and it didn't really turn out the ideally. But
Yep.
um, I had a kid that was almost going to die on me with typhoid fever,
Yeah.
and just some of the crazy wazoo off the wall stuff. I loved it. I
Yeah.
love being able to do way more. I had way more autonomy and freedom of
Yeah.
maneuver with whether Afghanistan, the Philippines, wherever it was. And most of my stuff was like just civilian clothes, just
Yeah.
go out. Hey man, I'm gonna go check on these guys.
Yep.
And being able to do not only that, but help provide key information that would help out the rest.
Yeah. And that's the thing. Like it's listening to some of the talks about the mission. Like I think back to my first deployment when I was big army. I did 16 months. Like I had Iraqis bringing me their CT scans. I'm like, yeah, that looks real bad. I don't know what to tell you. I'm not a real doctor. Just play one on
Yep.
TV. But like it makes you realize that when you got that the med patch or whatever, if you're wearing the cross, the Red Cross, you are a ambassador wherever you go.
Hmm.
And having that, like, that's another thing too, is teaching medics how, like, hey, be like, compassion. So
Hmm.
that's one thing I want to talk about training scenarios with you. So like that's like, what do you like to see in your training scenarios that like that gets medics conditioned that learn compassion and that realize like, hey, the person that I'm treating right now is a human being having the worst day of their life.
Yeah. Well, and that's one of the things I like to really drive home. I know when I first came in, we were a little like pain management. That
Mm-hmm.
whole mantra of pain's the patient's problem. That that is so bad and toxic for everything because it's not. Cause,
Right.
and I will tell you that the biggest thing is if they haven't experienced it themselves, well, that's usually the best way for the people to realize it.
Yes.
But when you have those the big mongoloid mite that just got hit and got a bilateral amputation, and they're bawling their eyes out, and or just the screaming from the pain, like
Mm-hmm.
those things. It only took like once, and I was like, man, something's got to go. And
Right.
then and trying to build that story and kind of I guess relay those experiences.
Right.
Um, I remember just going through the basic AIT. I had the opportunity to, I mean, do rotations and sit
Right.
in the corner watching the adults do work. But I was the only one that wanted to go to the burn ward,
Yep.
and I worked
Yep.
both fresh and post long term recovery.
Hmm.
That's an experience.
Yeah, man. Actually, I think I actually when I went through AIT, I did a burn rotation as well. So okay, our lives are not so different, you and I. Actually, I'm gonna like I think back to when I realized like, hey, like these are humans and people with feelings. Like did a JRX, like I think it was the first JRX they ran out at ATF. One of the role players, like I was being a smartass, sarcastic asshole of a young medic. I said something, and this role player came up off the freaking cot, grabs me by the throat, and resets me for me. And like I wish I knew who that guy was, and like shout out to the JSOC dudes that put that on because like it reset me to realize like, hey, the patient hears you,
No.
and you can talk like so much of what you can do for that person is just communicate with them. It's like, hey man, this is going to suck. And I'll watch this in the hospital. Like I was on a rotation in Cincinnati. A surgeon's doing a chest tube. This patient in the ICU is fully draped, and no one's talking to the patient. Like it's not a
No.
dig on any of the staff there, but it just made me realize like we get so complacent that the tissue under the sheet is connected to a pretty big computer that processes things.
Yeah.
Um,
I think there's a good correlation between that and so like the targets for basic shooting qual.
mhm.
They were specifically designed like that way, so they didn't look very humanistic, but it still was able to get the training done.
Right.
I think we've done a very similar thing behind um, choosing our training modalities and then how we're doing it. And I think yeah, there's a time and place for all the different modalities of medical training, and as long as you know how to actually employ them and utilize them the appropriate way and not overstepping,
Right.
because that causes a lot more scars. But that I think contributes to desensitizing the human from just doing the things.
Right.
I mean, I've seen my drugs work so much better and longer when it's like, hey, dude, I know this sucks, man. I'm with you. I'm working with you. I know this lollipop probably isn't going to address the pain that you're in right now. Like, hey, man, I'm here for you, dude. Or
Yep.
I'll grab somebody
Yep.
else. Like, hey, just sit over here, just talk to him, man.
Yep. Yep.
And the number of like instance like reemergence from
Hmm.
ketamine, dude, just talking to him and just getting their mind distracted
Yeah.
or simple things, or just covering those wounds, those devastating wounds. There's no
Yeah.
business, no need to see that.
No. Well,
I
and to
could
be
take
fair,
that away, reduce your anxiety.
yeah,
My drugs work better, faster, longer.
it's a psycho like the psychosomatic effects that we can like implore on people. And it's not the right word, but whatever.
Yeah.
It's powerful. It's
Mm.
so powerful. Like man, I wish we could take every medic and shoot them. No, it's a joke, just not really, but like give them a
Yeah.
traumatic injury that they have to recuperate from, and it would change their practice drastically. Like, so I went and got surgery. I asked anesthesia, "Hey, ketamine's my frontline drug. I've never experienced it. Can you induce me with just ketamine?" And they're like, "Yeah." So they hit me with 500 milligrams of ketamine, and like if I was not prepared for what I went through, like because I went to the emergent zone and my body detached like the classic, like I was
World.
looking down at myself on the OR table. I'm like, this is weird. And I'm talking to the anesthesia providers through the whole thing because like they weren't coaching me. It was like, hey
Yeah.
guys, like you're giving a major mind altering dissociative drug. You might want to get them ready for the ride.
Yep. So I remember I did my rotation down in Tampa.
Mm-hmm.
I spent a little bit of time working in the peds, which my hat's off to
Oh,
any
bro.
provider that's their thing. Uh,
Mm-hmm.
uh, Man, it's impressive but very difficult.
Hard work.
Had this kid come in, real bad burns. I think it was like a gas grill exploded.
Mm.
Um, and I'm sitting there rolling in. I'm thinking, all right, time to go to town, start doing everything. And the nurse stops everyone, puts on Barney, And I was like, yo, what are we doing? Like, and then afterwards, then she gave me the whole thing, ketamine, told me to push ketamine. First time I ever pushed ketamine.
Hmm.
Pushed it. Afterwards, I'm like, what was up with that? And explained, like, it just helps. It gets their mind off of
Yep.
it.
Yep.
And I was like, quite honestly, maybe we'll probably pick something better than Barney because that probably scared the crap out of me. But and those are some of those, like, again, some of those like defining moments that you just like pick up and they
Yep.
just kind of stick with you. But really kind of made me kind of think about, all right, it's not just a, a high fidelity simulator or a lump of flesh. Like, this is a person that
Yes.
if we are able to get him out of this or them out of this phase afterwards, the mental health, the long term
Uh,
aspects,
I,
just
I,
remembering that pain and remembering that situation of being alone and just
yep.
because everything I'm going to do is probably going to hurt.
Yep. Well,
Need it, but it's
you're,
probably going to hurt.
you're setting me up for the perfect segue that I love to talk about. So like it took me a while. I don't remember where the light bulb shifted. I think a Mod Hawk was probably a contributing factor to it. Where getting someone alive to a role two is not a win for me anymore. The role
Yeah,
two is the first level of surgical care in the military health system. My thing was like, I want to know what their quality of life is and how fast they walk out of the role four, which is the rehabilitation and recovery facilities.
yeah,
And that was my shift. And that's one thing for anybody listening who's training medics or anybody in the space is stop thinking about the short term victories, think about the long term quality of life impacts that we can do at the field.
right.
There's another brief story. A friend of mine, unfortunately, was killed in the line of duty, Dom Collada, but the other, rest in peace, sir, the other deputy that was out there with him was the SWAT commander for the county team. He got shot in a place that non-compressible, like a very dangerous, massive hemorrhage site. The first deputies that got on him aggressively, simply treated it, and the guy walked out of the hospital like a couple days later.
That's
And it's
amazing.
because of simple stuff. But like to me, that's the win. And like because he walked up on stage under his own power for the memorial, which was like a week and a half later, because of
Yeah,
simple treatments done in the field. And to me, I called those guys. I talked to the deputy who was the first one who did it. Still a friend of mine. I was like, hey, dude, like what you did in that moment to aggressively do simple stuff made like changed the outcome of Rich's life forever.
yeah,
And it was awesome. And those stories, like it's having these stories in our toolkit that we can bring to the next generation is huge.
yeah, yeah. And that's one of the things I think for the longest time, and I mean, it was the vast majority of medics while GWAT was going, and you had, I think, across the board, most medics had a decent number of saves or patient encounters.
Mm-hmm.
Now, not so much.
Right.
Now, like, it's hard to find somebody that's actually treated a real casualty.
Which is yeah, it's criminal in my opinion.
You know, it's one of those, like, it's really good. I'm not saying that we want to get a bunch of people messed up, but again, it's
Well, let me clarify that it's criminal in the manner that we are not setting up our pre-hospital medics with training experiences that give them the real world experience.
so,
Because
yeah. And one of the things that, and I know you guys touched on a little bit, there was, I think, the one big thing that we kind of got wrong, um, not intentionally, but seeing medicine, military medicine, and civilian medicine is completely different.
mm-hmm,
I don't see it that way. I used to for a while, but it's really not.
it's not. No.
It is the medicine is medicine. We're just the same things I do in the military, whether or not it's legal within the thresholds of your scope of practice or whatever, national
Yeah.
standard care, whatever it is. My goal should be giving that the highest quality using the best methods of treatment. If I cannot do that because of the environment, the stressors, the threats, whether it's a house fire or a Tesla that's about to explode full of fireworks or something,
Too soon.
or it's an IED blast or a firefight or something,
Yep.
that's going to cause me to deviate.
Yes.
And if we think about that from just a training and break away this whole made up divide that is completely different, because that has led to the hospital. They don't want anybody want a military because you do military medicine.
Right.
Their thought is you're going to jump straight to a crike and biolat chest tubes
No.
for every single patient. And but I think that has essentially uh, precipitated or led to kind of where we're at now. So we
I 100% agree. Like, there's no such thing as these branches of medicine, in my opinion. Like, yes, there's specialties in a hospital that have certain focus points, but like military medicine is just, you said it, it's medicine in
yeah
bad places, which is
yeah
also known as austere medicine, which is
mhm,
also expedition medicine, which is also cruise ship medicine. Like,
yeah
there are, like, I John and I talked about it briefly, but like, I look at the under-resourced federal health systems we have in the United States of America, Bureau of Prisons, Indian
yeah
Health, VA. Like, we have the access with like systems that are getting their asses kicked, where we could a call to action Congress, where we could put military medics to enable and help. We already have the conditions set from the VA. Shout out to the VA for their what it's the intermediate medical technician or whatever it's called. The conditions are set in the federal health system for medics to walk in and be credentialed at a level where they can help and touch patients.
yeah.
And like,
Well, yeah, and I think there's. I mean, I've seen. 'Cause I mean, trying to drive and run some of these programs for the civilian EMS or
mm-hmm.
law enforcement's always tough because there's like they all want it and need it and see the value, but the budget is just never really there. They're not given that investment.
Yep.
Um, but I think if we start doing that, I mean, hell, you can grab one experienced medic in some rural area it's so hard to get to that could set up essentially not a UW clinic, but essentially
Right.
one of the clinics we've all set up,
Yep.
and we can manage all of that with telehealth communications,
Mm-hmm.
like an iPad, and like, hey
Yes.
doc, hey man, here's what I got so far. Cool, thumbs up. All right, and they could provide substantial amount of care, at least
Yes.
for like stopgap until they can develop some real medical infrastructure in those
Right.
areas.
The model, like you see with the community paramedic model, like it's there.
Yeah,
I think the issue that we have is, again, a lack of imagination at the non-medical level, to because right now, like, we can jump up and down on the table all day long from the health services support side of things, but
yeah,
until I have a sponsor who is wearing stars, who's non-medical, to champion this across the finish line, or, to be fair, actually the best way for this to come to fruition is a elected representative who
yeah,
is on a certain powerful committee to tell DOD, you're going to do this.
yeah,
Because if you look at change, and that's one of the things we talk in circles all day long about, how we can, like, we can't do a lot of things internally because it requires, like it just, the staffing of things is atrocious. But if somebody writes in the NDA, National Defense Authorization Act, that all 68 whiskeys, medical techs, IDMTs, IDCs will touch this many patients every year, now you have to. It's policy.
yeah. So, and some of the really interesting things. Eh, have you looked in, seen much on the precision medical education concepts?
No.
Very interesting. And I can send you a couple of links to post and
Yeah, that'd be
wherever.
awesome.
Um, but it's re-looking at how we were doing not only sustainment but just ongoing uh, training. It's where
Mm-hmm.
it's a little more interactive, and I won't do it full justice, but because I'm not a learned doctor yet, um, but they go and do a simple workup. Let's say because the vast majority of things medics are going to be dealing with are sports med,
Right.
but rolled ankle,
Yep.
very basic clinical.
Mm-hmm.
If you're not an expert in the military, you're probably not in the infantry
Yeah.
or any kind of. But you go and do that first write up on, say, a grade 2 inversion sprain,
Hmm.
and being able to capture and quantify kind of all that data on patient contacts, and then follow up that grade 2 with a little deeper. And
Yeah.
especially now with technology and the way learners are now, instead of where I would go through PubMed and find all these articles and read through a bunch of articles and do that. Now you can get a short 5-10 minute little video snippet,
Hmm.
little deeper overview, talk about some other differentials. And like that's one thing that just medics working sick call. I learned
Yes.
so much when I was at Ranger Regiment because I had my platoon, and before they saw anybody else, I was responsible for doing the full assessment,
Yep.
doing a. I mean, it was standard. I don't know if it's just because it was just me, and they just wanted to push me a little further. But it was a 5-page soap note, a
Yep.
complete review.
Mhm.
Rolled ankle, sore tooth, didn't matter.
Yep.
5-page soap note, and I'd go present it to the docs, whether it was Doc Detro, Doc Cotwell, Miles, any of them. Present what I got with my plan and everything,
Yep.
and then over time, they're like, okay, cool. Now you can do all these other things. And that was really a lot of soft medics. They just want to focus on nothing but the trauma and the sexy stuff. But the development of those foundational skills and medical decision making, clinical decision, that's in just simple sick call,
Yep.
and being able to actually do all those things, or putting in those X-rays, or some of
Right.
those like smaller labs, or
Yep.
doing that.
Yeah, no, I've talked with this. Like, I think to talk with John about this too. Like, so, like, yes, that's how I was trained as well. Like, we ran in my Cav squadron. We ran sick call. Like, whether we started at the troop, we triaged. So you triage at the troop. If they need to be staffed, we brought them over to the aid station. We staffed them with the provider. We wrote the whole note in Alta. Like MHS Genesis, there's some workarounds. Like, it's getting there. It will get there. Like, because it has to. But like right now we regressed like the Soldier Center and Medical Home, which was an RV, like generate, like to be able to track RVUs, whatever the money term is for healthcare,
How much
which,
money you get for doing things?
yeah, yeah, because like hey, yes, TRICARE is appropriated, but they're still billing to TRICARE to make sure that it's appropriated accurately. But
Yeah.
it was the single greatest point of failure for our medics because we took them out of the treatment chain. Because yeah, like I full soap note, system above, system below, full head to toe workup, psychosocial freaking questions, like because that every single time someone would come to medical for something was an opportunity also to catch something more catastrophic that was hiding in the shadows,
Yeah.
especially psychosocial.
Yep.
Um, and that's my
Yeah.
again go.
Yeah. No, and that's where it actually it'd be an interesting poll to do. Um, I remember, and I'd be willing to say that the frequency of your team guys calling the medic first, like, hey
Mm-hmm.
man, my kid just do this, whatever. What do you
Yeah.
say? I'd be willing to bet that that is almost non-existent now, where I still get phone call. A lot has definitely dropped off, not as frequent, but I still get phone calls from
Yes.
some of my old guys. That, yo, dude, hey, I got this thing going on. What do you think? Or what do
Yep.
I need to do? I
Yeah.
mean,
Like
most cool. Go to the hospital. But
it's funny you bring that up because I actually got a call one time from a friend who had just wrecked their car, was in a ditch with a dislocated shoulder, and I helped them. I talked them through telehealth how to tie their pant leg around the tree, put their arm in it, do
yeah,
like distal traction with external rotation, and like they popped it back in, and then the ambulance showed up. It's like the ambulance crew ended up bringing them a bottle of whiskey in the hospital because they're like, man, you're the hardest person we've ever met. But yeah, like it'd be super interesting to hear, like, hey, are you guys still like I, I have had some experience. Like I got to like Caleb Twilliger, a good friend of mine. We got to do a prolonged field care experiment in Yakima. So seeing behind the curtain of how platoon medics work these days, it's like it's interesting because yeah, you don't get that like kind of, and it's a rapport building tool too when your platoon medic sees you for sick call.
Oh yeah. But and that goes a long way too, because I mean, again, you get in kind of the psychology of it. I mean, you're going out to these places like whether you feel like you're that person or not, it was almost a driving factor of I need to
Yeah.
be as smart as I possibly can and absorb as much of that I can on everything because every single body that's I'm rolling out with, I'm not just the medic that's gonna be the fulfill the requirement to go out on a mission. These guys fully entrust their lives, their families, the everything that I am the guy. I
Yep.
am the one that either if I don't know the answer, I will get the answer very quickly. And I think once you remove that and you disconnect the guys instead of going to sick all to go see whatever PA or whatever contracted person at the clinic,
Yep.
no, they go to you
Yep.
because they trust you because you're that the person.
Right.
You know the operational side, but you know everything. And once you disconnect that, now it's like okay, well, the medic is just fulfilling a requirement.
And
To go.
that's what I'm seeing now, like from the command levels, where a risk mitigation tool that is not trained properly to be an actual risk mitigation tool.
Yep.
And you brought up something too about like during the trust and like my platoon sergeant, I was striker, so I had a lot more flexibility with the amount of crap I brought. But I
Mhm.
brought a lit dead ass kit bag full of medical books like CDMT, Merck, ferric pharmacopoeia. I had like 5 books on physical exam and musculoskeletal because that's what we saw. Because like my first casualty ever was my Paul Valentino, a good friend of mine from 114 Cav. Fell through a window while we're doing mount training, urban training, dislocates his elbow. Me being a dumb medic that like thought I knew stuff. I'm looking at him like that looks easy. I'm like pop, put it back in. He goes to Madigan. Ortho's like, who did this? I'm like, oh. And that was another humbling experience that I realized I don't know crap. I better get in the books and figure it out because like
Oh
it,
yeah.
I like didn't even cross my mind that you could impinge and like and occlude like literally pinch an artery in there and then you lose your arm. You're like, oh my bad, bro.
Yep.
Fortunately, it
All right.
didn't happen.
Well, it's funny you mentioned that. I remember I I hadn't even gone to soccer yet. I was working in the regimental aid station,
Uh,
and I'd taken a handful internal classes and everything. But I was there. Uh, Chris Hutchison had just
uh,
left for Swickham, and uh, and I wound up pretty much being in charge of the aid station.
right.
Not really in charge of anything because I'm whatever.
Yeah.
And guy comes in, one a little rippy guy. We sounded like he was just malingering, trying to get out of it. He was already going in the 82nd or whatever. And gastroenteritis. I'm like, whatever, dude. Cool. Write up a note, get him in there. Go. I hit up old John Detro, who's a regimental PA at the time,
Mm-hmm.
and I was like, "Hey, doc, this is what I got." He's like, "All right, cool. Just go ahead and I want to give him some antibiotics." So I was like, "All right." So I go to the pharmacy and look. I was like, "Oh, cool. All right, there's some clear fluid next to it." I was like, "All right, I know how to reconstitute. This is easy." I go in, bend over, pull down your pants, give him a little shot of I think it might have been Rosef. I can't
Right.
remember what, but come to find out, sterile water. Learned a very valuable lesson. If you never want anybody to come to sick hall ever again, do an IM injection with sterile water.
Dude.
But he starts profuse sweating, completely red,
Mm-hmm.
completely tense up, and I'm like, "Oh my god, I just killed this guy." I'm
Yep.
never going to sock him. I go in. I remember trying to tell Detro, um, and he just starts laughing.
Yep.
Like, "You think this is good?" He's like, "He'll be fine." But it's like those things. Like I I dug into
Yep.
pharmacology quite a bit and
Yeah.
learned my lesson. But if you're not doing those things in a more protected environment,
Yeah. I,
you're going to learn those lessons in a bad spot.
I love that you have a sterile water story too, because when I first got to my unit, we were on rear duty. They're still deployed, so we went to Madigan to work in like various clinics. So I worked in the immunization clinic. I was teaching another medic how to do an intradermal injection, and I had them draw up sterile water. And then I got the injection. I'm like, ow, why did that hurt so bad? Then I got in the weeds. Like, yeah, you're putting something that's displacing electrolytes rapidly out of the cells. It's
Oh,
going
yeah.
to hurt. You're like, oh, cool. Learn something new. But it's just funny that, hey, there's so many parallel stories that we all share of like, this is the dumb stuff we did. And here's something to learn from it. So, Eric, we're coming close on time, man. So I'm going to kick it over to you for any final thoughts, and then we'll wrap this up.
No, I really appreciate it, man. And definitely time went by way faster than I thought.
Hmm.
I guess one of the things I really wanted to push out, kind of tied into what we're doing. Um, One, if anybody out there is looking to kind of push the limits and really kind of improve their training, cadavers can definitely do it. But one thing that this we need to make sure we're doing, because there's been a huge increase in popularity and demand for it. And it's a critical gap that I've been really pushing as a kind of core mission. We need to establish and do the same work and provide the same kind of oversight that we do with live tissue and like the eye cook.
Hmm.
It does not exist. And I will tell you, being in this niche for 5 years or so now, it is such a slippery slope and dangerous if we do not, I guess, build the same infrastructure that we have to make sure it is ethically minded and
Hmm.
we're doing things that are actually going to be an advantage and not just a cool experience, if
Right.
you will.
Yes. Yeah. It's respect. It's donated tissue. It's a
Yeah.
human being who's said, "I'm going to donate myself for the greater good," and that should be handled with the utmost respect.
Yeah. And if any of the listeners out there are going to be attending SOMA, I'll actually be giving a talk specifically on that, as well as I'll be bouncing between the North Carolina EMS Expo as well, giving a similar talk on data-driven training. So
Awesome.
um, more than well, anybody's got questions or anything, happy to answer, jump in and help out,
Yeah.
whether it's us coming out to you or just giving you some tips and tricks and whatever I can.
Awesome, dude. All right, man. Well, we will make sure I'll get your info at the end of this. We'll throw it on the fade to black, as I like to do. That way, anybody out there listening can reach out to Eric, Eric Crouch of Precision Anatomy, Colossus in the pre-hospital space. Just the beard alone tells me all I need to know. Yeah, I'll see you at Soma as well, my guy. So thanks again
Awesome.
for doing this. We'll see you soon. And for all the listeners out there, thanks for listening. Splints and Whiskey coming at you every week, I think, these days. Yeah, about that. And then, too, yeah, throw it back out to our primary sponsor, Life Autonomous Care Consultants. Give them a look, see if they can help you out, and keep this show rolling. All right, man. We'll catch you on the other side.
Appreciate it, man.
Artlist.io